Thank you very much, Joan, and thank you very much, EAPC, for having this opportunity for us from the EAPC Research Network Junior Forum to have this webinar. I would like to say good day, because it's good morning, good afternoon, or even good evening to people around the world. And on behalf of the European Association of Palliative Care Research Network Junior Forum, I'd like to welcome all of you for the second webinar of the Junior Forum. My name is Gina Curita. As Joan has mentioned, I'm the Vice Chair of the Research Network, and I have the special task of managing the Junior Forum with the steering committee composed by the Junior Forum members since last year. And here with us, we have today 3 of them. That is Carolina, you can see on the screen, Babita, and Bharati. And if you'd like to know more and to know who are the other ones that compose the steering committee, please follow us in the page inside of the EAPC web page. Joanne is going to put a link here where you can see the aims of the Junior Forum and know more about us. We have a very tight schedule today, but I would like to invite then all of you that are not members yet of the Junior Forum to become a member. You just have to subscribe, it's for free. Babita has put a form for you here in the chat where you can download, and there is an email where you can send it back. It's very important that anyone can affiliate. It doesn't matter how old are you, or which level you are in the research in palliative care. The important for us is that we can increase our network and the possibilities for collaboration in research inside of palliative care. But let's return to the webinar. And today we have then 2 members of the steering committee that will host this event. And they are Carolina Duklova. Carolina is a psychologist in research at the Center for Palliative Care at Tomaya University Hospital in the Czech Republic. Carolina, she works clinically in palliative care and also investigates prognostic awareness and delivery use. She also developed the Czech version of the Integrated Palliative Care Outcomes Scale, what is very interesting here today. And we have Bharati Bhattavattasalu. She's a physician and researcher in Germany. She's researching the experiences of hospitalized people in advanced COPD. And she's also volunteer faculty at the Paleo in India for various palliative care courses. Please, I would like to invite Carolina to introduce this webinar to us.
Thank you very much. So welcome everyone to this webinar. So the structure of this webinar will look like that. First, always one of the members of the steering committee of Junior Forum will introduce their work. So today we will hear from Bharati about her research work, and then we will have a speech and lecture from Professor Claudia Bausewein. And after that, we will have some time for questions. So if you will have any questions, please write them in the Q&A box, and we will go to them at the end of the webinar. So now it's your turn, Bharati, to introduce your work.
Thank you, Carolina. I'm just going to share my research work that I've done with people who are hospitalized with advanced COPD. So the background for this research is that individuals with advanced COPD are frequently hospitalized, particularly for acute breathlessness. Hospitalization can itself increase morbidity and can cause financial burden, although it can provide immediate symptom relief. Despite repeated hospitalization, people experience difficult symptoms while being hospitalized. So this study explored what is it like to be hospitalized at the advanced stage of COPD. A qualitative phenomenological study was employed to study the experience. 15 patient participants with advanced COPD, according to the goal stage 3 and 4, were recruited from a tertiary care hospital in South India. Unstructured interviews were conducted at the inpatient wards, and Georgi's descriptive phenomenological analysis method was used to analyze the data. 15 participants were included totally, and there were more male participants with the age ranging from 61 to 83 years. Time of hospitalization ranged from 2 to 18 days. So findings showed that people had repeated hospitalization which were frequently emergency hospitalization for breathlessness. People felt that they had a feeling of sense of safety. At the same time, they feel a sense of the daily routines were disrupted. And there was also a perception that hospitalized was perceived as a necessity. At the same time, people preferred to avoid it due to difficulties involved with the repeated hospitalization, such as financial and care burden. So as you see on the quotes on the right side, it can explain this dilemma between necessity and avoidance. So the quote below explains that, what can I say? Shall I remain at the hospital thinking that I will be fine if I'm in the hospital? Or shall I remain at home thinking that I would become all right if I'm at home? So these dilemmas were often perceived by patient participants while being hospitalized. Hospitalization associated with a lot of uncertainty and anxiety, mainly due to unpredictability of treatment outcome. Treatment was perceived both as beneficial and burdensome. Beneficial because it provided immediate relief, burdensome because it associated with the financial and other care burden. So again, you can, this is well explained by the quote on the right side, that a participant describes this experience as, oxygen is like my father, neither of them can stay without each other. NIV is like my husband, neither I can stay away from it, nor I can embrace it. And apart from this, attitude of the staff influenced the perception of care, both in a positive and negative manner. When staff were concerned about the patient's needs and listened to them carefully, it had a positive impact. But when they ignored, their concerns were not listened, it had a negative impact on the hospitalization. Overall, there was a poor understanding of prognosis of COPD. Trust in hospitalization was mainly promoted by immediate medical attention, availability of experts and facilities of the hospital. And care mainly played a major role in developing trust in hospitalization. Multidimensional suffering was central to the experience, affecting patients' physical, psychological, and spiritual aspects. Although physical symptoms such as breathlessness received immediate attention, psychological concerns such as fear of death and anxiety, they seem to be not addressed. This led to spiritual distress, which was expressed by many patients. So this study tells us this hospitalization is a complex experience. It's a complex phenomenon influenced by multidimensional factors such as physical space of the hospital, availability of facilities such as equipment and experts, and administrative process like discharge and admission procedures, along with communication, which played a major role in the experience of hospitalization. Communication influenced care and treatment, which in turn influenced developing trust in hospitalization. And these factors acted at the backdrop of people with different expectations from hospitalization and culture from where their experiences were formed, and religion, which acted as a coping resource, and the context of illness, whether it is acute or chronic. So this study concluded that multidimensional suffering is central to the experience, and psychospiritual needs also requires equal attention as with physical symptoms. As an extension of this research, we found spiritual and religious aspects of individuals who are hospitalized need more attention because they become intense during hospitalization. So there were other questions raised, that what is their experience of spirituality while being hospitalized, and how people have coped with the stress of hospitalization with advanced COPD, and what are the religious coping strategies utilized. So these factors will be analyzed with this research conducted. So these are the papers published as part of this research. If If you want to contact me, these are the email IDs. And thank you for listening. Now I introduce Professor Claudia Bausewein, who's a director of Department of Palliative Care at Munich University Hospital. And also she's the president of German Association of Palliative Care. And she's an eminent speaker, and she's done a lot of research. She's particularly focused on outcome measures in palliative care. And today she'll be talking about IPOS, palliative care needs assessment using IPOS scale. So Professor Claudia Bausewein, please.
Dear Bharati, dear Jana, dear listeners from all over the world, thank you very much for attending this webinar, which gratefully the EAPC Junior Forum of the Research Network organized, which I think is really a great opportunity to share experiences and to discuss issues that probably are relevant to all of us around the world. I've been invited to talk about palliative care needs assessment using IPOS, and I want to put that in a perspective of outcome measurement, but present you also, I'm just seeing, now it's working, yes. So I want to introduce you to IPOS, the Integrated Palliative Care Outcome Scale in the context of outcome measurement. I want to demonstrate the use and advantages of using IPOS as part of vital signs, and I'm going to explain that, yes, later, in everyday clinical work. I want to show you how we use IPOS for screening for palliative care needs in oncology, show you a potential of using IPOS in an electronic version, and also where we used it in a research project to show the difference in palliative care needs in different specialist palliative care settings. So let me just start with the need for outcome measurement in general. When we talk about quality in healthcare, we very often talk about structures and processes and maybe outputs. The structures are really the staff we have, the equipment, the palliative care units, the home care teams, the syringe driver, the drugs we can use. The processes are related to, for example, the prescription of drugs, the use of syringe drivers, staff visits, ward rounds we do, etc. And output is related to productivity or throughput, so the discharge rate, the day hospice attendance rate, numbers of drugs we prescribe. But if we would stop here and think this is really describing quality in healthcare in its full, we actually miss how the patients and the relatives, so the recipients of the healthcare, are feeling. And that is why we need to look at outcomes as well. And I think it's very important, and there has been quite a movement over the last years and decades, really to focus on outcomes, the perception of patients, the problems of patients and relatives. And I think that's especially important in palliative care, because that's very person-centered, patient-focused. So the change in the health status and the quality of life that is attributable to healthcare, and in our case, to palliative care, is very important. So we can demonstrate and show how pain is changing, how other burdensome symptoms are changing, and hopefully we can also demonstrate that we can improve quality of life. These are only a few examples. And I just want to put that in the context, what we mean with outcome measurement and assessments, because they relate closely to each other, but they're not necessarily the same. So if we measure at one point in time the issues of the patients and their families, the problems they face, this is a one point in time assessment, which we can use for screening, for communication, for prioritization. If we repeat this assessment the second time, then actually the comparison between the first and the second assessments, or even continuous assessments, allows us to demonstrate the change. And that is then related to the outcomes of care. So this is just to give you an idea when we talk about outcome measurement, outcomes in general, how they sit sort of in healthcare and the discussion about quality. And over the years, there has been a strong movement towards patient-reported outcome measurements, so-called PROMs, or in the US, they call it PROs. And these are a form of outcome measure and comprise standardized, validated questionnaires that are completed by patients. So that is the important point about patient-reported outcome measures, that they show us their view, that they answer the questionnaires from their perspective. That means we are measuring their perceptions of their own health status and well-being. Although PROMs and patient-reported outcome measures are really highly relevant in palliative care, we obviously have a huge challenge because patients are deteriorating over time. They might be cognitively impaired, they might be delirious, there might be many reasons, and then in the dying phase as well, where they can't assess their situation and give us their personal perception. And that's why Simon Atkind and others suggested to use the term patient-centered outcome measures, PCOC, which is still around the patient and the family, but they can be both patient self-reported, but also proxy-reported. Proxy-reported means that we as professionals, or in some instances, sometimes the family, might assess the situation of the patient. But there's nevertheless the prime focus of the concerns that are important to patients. And I think that's highly relevant, as mentioned before, in palliative care, because when patients are deteriorating, when they enter the dying phase, we must not stop to measure their outcomes or to assess their outcomes and their situation, but we might have to do it as proxies. And we know that there are huge limitations about that. But obviously, if we look at outcome measures, those are very attractive that include both perspectives, the patient-reported and the proxy-reported, or then finally the patient-centered measures. And the integrated palliative care outcome scale, and I believe that many of you are familiar with it, is one outcome measure that is around in palliative care for almost 15 years now. It is a measure that has predecessors, the patient outcome scale or the palliative care outcome scale. The POS was the original version developed by Irene Higginson at the Cicely Saunders Institute in London. There was also a symptom list and then an African version, the African POS. And they all measured patient symptom burden, problems, and concerns. And based on these three measures, together with Irene Higginson and colleagues from London, we developed together a newer version of the POS, which we then called the Integrated Palliative Care Outcome Scale. And I show it to you in one of the next slides. There is a 3-day version mainly used for inpatient use and a 7-day version for community use. 3 days and 7 days in this case means the time that you're looking back when you're asking the patient, how is your pain, how's your breathlessness? It says over the last 3 days or over the last 7 days. There are overall 70 questions. Well, actually it's 10 questions, but one has a list of symptoms, so it's 17 items. And there's a 5-point Likert scale from not at all to 4 overwhelmingly. You can sum up the scores to not to 68, and I'll say something about the sum scores in a minute. And it's one of the few measures where you have a patient and a professional, that means a proxy version. And that's the beauty about this measure, that you don't have to change, that you can actually use the same measure just from a different perspective. As you can see, there are a number of further developments for special patient groups or special situations. So there's the IPOS Neuro with specific neurological symptoms. There's the IPOS Renal with specific renal symptoms. There is now a version for dementia patients, which actually is quite different to the original IPOS, but based on it. And then tuned into the specific situation of dementia patients. There is an IPOS views on care version with 2 extra questions. I have it if we want to discuss it. And one of the latest publication was actually an IPOS version, the symptom list specifically for COVID patients. And you can see here, I've downloaded it from the POS website where you can get all the information. It's written down here on the right side where you can get all the information about POS and IPOS. It's free to use. You only need to register. And I just got here the latest translations. You can see now that IPOS is actually quite an international measure. It's translated in various languages within Europe, but fortunately also far beyond Europe. So there is a Malayan version, a Persian version, a Chinese version, a Korean version, and many other languages as mentioned before. I actually included some of your questions, which I've been sent to yesterday. And one question was actually that one of the participants is interested in how to assess the total IPOS score. And I show you the IPOS in a minute, so it's a bit early. But as I say, you can sum the items up. The question is, are we really working with that, both clinically and in the research context? The challenge is that you have to be sure that the patient is really completing all the items. And there is an option for cannot assess, especially for the proxy version. And if you cannot assess 1 or 2 situations about a patient is in the dying situation and you're not sure is he or she in peace or not. So once you're not answering one of these questions, actually you get lower scores than the actual situation might be reflected. That's one of the reasons why the sum scores are actually not used that often, but it's much more interesting to use at the individual scores. And if you have a group of patients, again, you need to make sure that your scores are not underscored in a way because you have lots of not applicable or not accessible items, and which might skew your data and introduce a bias. So here is the IPOS in the sort of in full. It's starting with an open questions about the main problems and concerns over the past 3 days. And then the patients are asked about how they are affected. Many tools actually measure the intensity or the strength of symptoms, for example. But the IPOS looks especially about how the patients are affected by their symptoms. So, for example, they might have very strong loss of appetite, but they're not affected by it. You all know patients who really look short of breath, so we would assess it as a strong shortness of breath, but the patient might say, I'm actually not affected by it. So the question about being affected introduces even more the patient perspective. Then we have a symptom list of the most prevalent symptoms here orientated for cancer patients, and that's the original version. But as mentioned before, there are now individual symptom lists for other disease groups. And because the symptoms listed here might not be the symptoms, all the symptoms that the patients are suffering from, so they can also add their own symptoms. So if somebody is suffering or affected by itch, or if somebody is affected by diarrhea, but this is not listed here in the symptom list, then they can actually add it and then again assess how affected they are. Many lists that we know and many tools that we use in palliative care are focused on symptom burden or intensity of symptoms, but we know that our patients are not only physical symptoms, they actually have a psychosocial and a spiritual dimension. And that's the second part of the IPOS, focusing about whether people are feeling anxious or worried about their situation, about their illness, whether the family is feeling anxious about the situation or illness of the patients. Then the question about the mood of the patient. So have you been feeling depressed? Have you been feeling at peace? And which is a surrogate for spiritual existential questions. Have you been able to share your feelings with family and friends? A question about information and one question about practical issues. Obviously, no assessment tools will make a conversation about the situation with the patient not necessary. So you're not substituting a conversation, but you can focus on the situation. The patient gets a voice and can show his or her concerns. And when you see them in your consultation, you actually have a guidance where you can much quicker go into the situation of the patients. The other way around, if you're assessing a patient and you've got the main IPOS questions in mind, that obviously gives you a structure, what to ask the patient, that you don't have any blind spots. And we are very comfortable of focusing on pain and other symptoms, but we might not be as comfortable to ask about the spiritual concerns. So have you felt at peace might be a question that is helpful for you. And that's all covered in the IPOS questionnaire. There was a question about the interest, that was the question I discussed before about the total IPOS score. And as mentioned, you can, there are versions here where you have an answer option of not applicable or can't be assessed. That's obviously then the proxy version. You see here, I brought you the patient version. And again, if you have items lacking, which can't be assessed or which have been forgotten, then obviously you underestimate the need if you only use or focus too much on the sum scores. Another question came from the audience asking about the robustness of IPOS in the sub-Saharan African context. I thought that's a very interesting question. I'm not aware of any publications or validation in sub-Saharan Africa of the IPOS, but the reason might be that there is the APCA African POS, which has been developed by Richard Harding and colleagues, again from the Cicely Saunders Institute in London, and they used the original POS and developed a version that is valid and reliable in the sub-Saharan African context. And you might actually find, for example, the question about have you felt at peace? The reason why we included it in IPOS was actually because it was used in the APCA African POS. So probably this is the instrument much more used in the African context, and I'm not aware of a study where IPOS has been used in this context, but I don't think there is a reason not to do it. But it probably would be good to contact Richard Harding and also see and hear to his views. So how can we use IPOS in everyday clinical work? When we talk about outcome measurement, we obviously talk very often about research, and you use it as an outcome measurement to answer your research questions which might be related to palliative care needs. But we are very interested in using IPOS in everyday clinical care. And I want to show you how we do it here in Munich in our department. We use IPOS as part of our routine clinical assessments, and I'll show you in one of the next slides which assessments we used. There are obviously different timings possible for assessment. We use it at baseline when we first see the patient. We use the symptom list of IPOS daily, and again, I show you a bit more in depth how that works. We also use phase of illness or palliative phase. So we use the full IPOS when we change or when there is a change in palliative phases. Another option which we actually left because we are now using it much more regularly in everyday work is you can also do it just before the weekly team meetings, that you say, okay, the day before the weekly team meeting, we do an IPOS assessment, which then we then can discuss at the team meeting. Obviously, it's interesting to assess the concerns of patients before discharge, because then you can compare it between admission, for example, and discharge. And in our outpatient clinic, we ask patients to bring a completed IPOS to the meeting and to the consultation. And as I mentioned before, this will actually focus the conversation and hopefully unveil problems of patients very soon and immediately, which you can then discuss and tackle. As mentioned before, we mainly focus on individual items because we feel that the sum scores are actually clinically less relevant, because you might, for example, have 10 items where the patient is scoring, they are moderately affected by a situation, so that would give them a 2 each time, which would make 20. But you could also have 5 items where they say, I'm overwhelmingly affected. And that obviously would be a difference in the approach, because if somebody is overwhelmingly affected in several items, there might be a much higher need compared to the moderate affection but in many items. That's why, again, we are a bit critical about the sum scores and don't use them so regularly. Currently, in the clinical context on palliative care unit, we focus very much on proxy ratings, but are discussing how to introduce patient ratings if that's possible. And that's especially in the inpatient setting, obviously a huge challenge, because I would say about 2/3 of patients are not able to complete IPOS themselves. And we use the scores in the everyday morning handover and the weekly multidisciplinary team meeting. We present the scores and discuss them. I mentioned before that we introduce or include the IPOS into our clinical assessment. And just to show you how we have decided to do it in Munich, based really on the PCOG work from Australia, but also work from Fliss-Murter in Hull in England. If we talk about the situation of our patients, we know, and Cicely Saunders told us that very early about total pain model, that we have to focus on physical symptoms, but also the psychological situation, the social situation, and the spiritual existential situation. So measuring the burden of physical, psychological, social, and spiritual existential dimensions, actually IPOS will cover with 1 or 2 questions or items every of these dimensions. We also use the problem severity score, measuring the intensity. That's a much shorter score. We're using the, as functional status with the Australian Karnofsky Performance Status, the AKPS, and on the ward also the Bartel Index. And we work very much with palliative phases. We can discuss that if you're more interested in that later on. And that actually gives us a common language. It does take a bit of time to teach people that they understand it, but if you can say how the palliative phase is, what the AKPS is, what the problems, the main problems are, for example, on IPOS, then you get a sort of frame, a picture of your patient, which helps you to plan your care better or to prioritize patients, for example, at ward rounds. So that's how we use them on admission. We do sort of the whole battery, and IPOS is obviously very central. The daily contact, we use the symptom list of IPOS, and when there is a phase change of the palliative care phase, we would actually then complete the whole IPOS and the other assessment tools as well. And at discharge, again, we would use all the assessment tools. And the experience is, and the data shows, that we have about 2 to 3 palliative phases per hospital admission or palliative care unit admission of about 10 days. But this daily symptom list is helpful to monitor the symptoms, to see how the treatment is working, and obviously where we need to adapt our treatment. For us, life was much easier when we introduced or included IPOS in our electronic patient record. And I told you it's a 5-point Likert scale, from not at all to overwhelming. We actually use colors as well, because then it's even quicker and easier to see how the situation is. That's obviously, I'm sorry and apologize for the German, but that's just a screenshot from our electronic patient record. So these are the items, the symptoms that I showed you before from IPOS. There is an additional symptom. This patient also suffered from itch. And this is the second part of the IPOS. There are various reasons why we have here another list in between. I can explain that later, but I think just for now this is the second part of the IPOS items, focusing on the psychosocial, spiritual and practical concerns. And you can see here, that's probably because of the screen. Here's the palliative phase, which would be here deteriorating, and you have then the dates actually of the assessments. And you can see, hopefully, there's lots of green, meaning there is hardly any burden or no burden. And then when it's getting darker, the darker it is, the higher the burden of the patient is. This is to show you how you can then use the data of your patients if you analyze them as a whole group. We have analyzed here about 600 patients being admitted to the palliative care unit. And again, here, these are the IPOS items. And you can see here the same items on discharge. And if you compare them, you can see that there are mainly reductions in the burden and in the palliative care concerns of patients. Reducing family distress here with more than 50% actually remained the same. First, we find it's quite challenging, because even if we can help relatives and families and support them, some of their main burden and concerns actually still remain, even despite the time on the palliative care unit, mainly also related because in Germany about 60 to 70% of patients die on the palliative care unit. So it's a really very burdensome time for many people, but you can sort of demonstrate and show that when you analyze IPOS and compare it like this. This is the prevalence of symptoms or concerns in relation to the palliative phase. The phases are stable, unstable, deteriorating, and dying. This is on admission. So if a patient is classified as stable on admission or unstable, these are the related items. And what we've done here is actually we define prevalence as moderate, severe, or overwhelming infection or burden of the concerns or of the symptoms. And you can see, obviously, patients in the unstable phase have much higher palliative care needs and symptom burden compared, for example, to the stable phase, which you would expect, but that shows you that the phases are actually a very good addition to show in which phase of their illness the patients are at that moment in time. So that's how we use IPOS in everyday clinical care on the palliative care unit. We also thought that IPOS might actually be helpful for screening of palliative care needs and the need for specialist palliative care in general oncology. And I want to show you a bit what we've done here. We thought IPOS could be helpful for the discrimination, who would be fine with generalist palliative care and who needs specialist palliative care. So we conducted a small study in medical oncology with 150 consecutive patients. They provided us with 208 cases. And the idea was to assess the symptom burden of these oncology patients and evaluate IPOS cutoffs. And I'll talk about the cutoffs in a minute, to compare performance criterion validity of IPOS and distress thermometer. That was the second we used, and assess the construct validity of IPOS in comparison to the distress thermometer. So we asked patients on admission to complete the IPOS in medical oncology, and we did it on all patients, which was actually quite interesting. And we, from a clinical point of view, discussed what could be a good cutoff for screening. And we decided that high palliative care needs would be defined as 2 times overwhelming or 3 times severe ratings on the IPOS items. And if it's lower than this, so neither 2 times 4 nor 3 times 3, then we would classify it as low and medium palliative care needs. And then the oncologist would provide generalist palliative care, and in the other case, we would involve the palliative care consult team. So we had 140 patients, as mentioned before, variety of diagnosis, but because it's a very hematology focused department, many patients with lymphomas and leukemias, but also some with solid tumors. And we classified them at early stages with about 23% of patients, and about 3/4 of patients were in the advanced stage of their illness. But overall, these patients were quite fit. You can see that almost 80% had a Karnofsky performance status of 80 to 100%. Obviously, they were mainly coming to get either chemotherapy treatment or diagnostics. So these were not classical palliative patients or palliative care patients, but you know that we discussed the early or timely integration of palliative care into oncology. And we identified that 88 of the 208 cases actually had palliative care needs. And if we look at the IPOS items of the overall group, so all patients, you can see here again the IPOS items. You can see, so the darker the color is, the more burdened patients are. And you can see overall that the psychosocial and especially family issues actually are ranked quite high, that symptoms are existent, they are prevalent, but the symptom burden is sort of overseeable and not too high. But if we compare to the two groups who either rated 2x4 or 3x3, so that is the high needs group and the low needs group, again, you can see nicely that those with higher needs actually had, and I apologize again for the German items here, but here it is pain, breathlessness, weakness, nausea, vomiting, etc. And again, and that was interesting, the worry and the anxiety of the family was almost similar in both groups, although here was higher burden, but obviously that is an issue earlier in the disease trajectory or already in oncology patients. We're still analyzing the data, so this is the sort of some of the first results I show you here, and just to give you an idea how we use IPOS for screening. And just to complete that, we are very lucky in that the German Cancer Society certifies oncology centers, and they actually ask for routine screening. And it was mandatory to introduce screening for psycho-oncology, nutrition, pain, and palliative care. And we have IPOS at the moment as a paper version, but we also use a short version of IPOS that is published on the POS website, including pain, shortness of breath, feeling anxious, feeling at peace, and information needs in a broader digital screening. So patients are now getting the opportunity to screen digitally, and there are 5 IPOS questions included as well. So that was one of the questions you asked as well about use in generalist palliative care in the hospital setting. This is obviously the edge between generalist and specialist palliative care, but hopefully IPOS in the future will help us to discriminate patients who need more palliative care, specialist support rather than generalist palliative care. Another development over the last years is that we developed an electronic version for assessment of palliative care needs in specialist palliative home care. The idea was to test the feasibility of a structured recording using EAPC, the electronic IPOS, which was done by the patient at home and directly transferred into the electronic patient record of the specialist palliative home care team. And that was our hypothesis, would obviously help to shape care and timely integrate these results or what the patient has put into the EAPOS. We wanted to actually test the feasibility mainly. So the question was, who's actually able to complete and to take part in such an assessment? We screened, as you see, more than 1,700 patients. Only about a third or 25% met the inclusion criteria. And that was mainly related to not being too distressed or too ill to participate. And as specialist palliative home care in Germany is very much related to the end of life and mainly the last days and weeks of life, that obviously made it very challenging to identify patients who then could take part in this feasibility study. So you see of 1,700 screened, at the end, we had a study period of 14 days, 60 only were able to complete it. But these 60 gave us 5.7 EAPOS assessments per patient, and overall we had about 500 EAPOS assessments. These are again the symptoms now plotted over 15 days. These are the number of patients who provided us IPOS scores. And again, here we have at least moderate symptom burden. So we didn't assess the not and zero or the not at all and slight versions, scores. And you can see over time, obviously it is quite challenging to change some of the items, especially mobility, anxiety, obviously remained high over the time. We also did some qualitative interviews on patients' use. And patients say, something has changed. And then they called me and asked me about it because the scores have been reported to the electronic patient record. And I thought that was very good. Yes, so it's already a more intensive contact, I think, through the questionnaire, meaning the IPOS. Another patient said that was helpful for me because I had to face my situation. I have to mention something. I did it and I got support. I can't expect help if I don't talk about it. And the questionnaire has opened the way for that to a certain extent. So some patients really found it helpful to feedback their situation to the specialist palliative home care team. Another patient said, but you have to be able to concentrate. The more visible it gets, the more you have to get you over yourself to each of these categories. And then it becomes more and more difficult. So over time, patients find it challenging, especially if they deteriorate in their situation. The healthcare professional said, for example, it was more helpful when it came to what patients do not say in personal conversations or on the phone that they're worried about, or that their family is worried. That often became clearer in EIPOS, in the electronic IPOS. Or here, a healthcare professional said, is she in pain? Somehow we didn't have that on our radar. So the patient reported pain, but actually that wasn't identified before by their home care team. And then very quickly, we also used IPOS to describe patients' complexity. And here I demonstrate you some data to describe the different palliative care needs or the palliative care needs in different specialist palliative care settings. That is here the palliative care unit, specialist palliative home care team, and palliative care advisory team or hospital support team. And again, we plotted here patients who were classified as severe or overwhelmingly, and the number of symptoms or items that they classified as such. And interestingly, we're talking about specialist palliative care, and it doesn't matter whether we talk about hospital setting, home care setting or hospital advisory setting, you can see that the burden is actually very similar. So irrespective whether it's community or hospital, the burden in specialist palliative care is quite high, but you can't say it's higher or definitely higher in palliative care inpatient or in home care setting. Even especially here, it looks like the home care setting, they have even more burden than in the inpatient setting. And the same for psychosocial needs and practical matters, again, very similar if you compare the three settings. So that was quite interesting for us. And then obviously it's even more interesting if you understand the various specific items. So summing up, there is obviously some evidence also showing that using patient-centered outcome measure has an effect on the care processes. Simon Atkin and colleagues published the systematic review in 2014, and they say it impacts on the process of care by facilitating identification of health-related quality of life concerns. So we're not talking about IPOS only, but general about patient-centered outcome measured, and providing a structured way to discuss these. But obviously more clinical actions are then necessary in response to the identified needs. And if we look on the effects on the outcomes of patients, there is actually at that time, the studies identified did not demonstrate an improvement in health-related quality of life, neither in symptom burden, but they could show positive effects on caregiver distress and positive effects also on mental health and distress for patients. So I think, again, there is some work to be done, really, and implementation is quite challenging, but I think it's worth it, and it does help to shape patient care. Finally, just some resources if you're interested. There are some booklets from the Cicely Saunders Institute, something on outcome measurement in palliative care that we have published more than 10 years ago, a guidance on the implementation of patient-reported outcome measures in clinical palliative care. Again, I mentioned the post-palliative care, post-palliative outcome scale website, where you can freely register and then download support material. There's been a white paper on outcome measurement in palliative care. Again, something more general. We are discussing at the moment whether we update it because it's 8 years already. And there's also another project which is providing very good training resources. It's called Resolve, run by Professor Fliss-Murter at High York Medical School. Again, you can download a lot of support material from there. So just summing up, there are challenges using IPOS to assess palliative care needs, but it is helpful to shape clinical care and to understand the population and effects of care better. Implementation is a challenge, it's certainly time and resource intensive. IPOS, we think, can also be helpful for screening, and I think there will be some publications coming up for palliative concerns. First experiences are in the cancer population. An electronic version will be helpful to support patients in specialist palliative home care, but it's only a small patient group who's able to use it. So we are thinking of studying also the use in generalist palliative care and in the community setting. And it also helps us to identify differences and similarities between settings and conditions. I want to thank my colleagues here in Munich who are working hard on outcome measurement and the use of IPOS here, and especially Julia Wickert and Katarina Riskova, who provided me with some of the slides that they used for presentations in other settings. And this is coming to an end. I hope I'm not too late, and thank you for listening and look forward to the discussion.
Thank you very much, Professor Claudia Bausewein, for that excellent presentation. And we are very fortunate to listen to your lecture and that the work that you've done in a variety of settings using IPOS. So now we have some time for question and answer session. So I already can see some questions in the question box. So we'll take the first one. Is the relation of phases and distribution of symptom severity published or described somewhere?
There is a publication from, I think, Fliss-Murter's group, and there's a publication from Australia. I would have to dig it up, but I think it's, yeah, I can probably send it to Joan. That might be the best, and if somebody's interested, but there are publications on that. We haven't published our data yet, but there are some publications referring to patient burden and phase of illness or phase of palliative phase.
Okay, thank you. There's another question asking, can you please explain again how you screen for referring to a palliative care team?
Sorry, say that again. How we screen?
How do you use the screening that with IPOS to refer a patient to a palliative care team?
Okay. So we are using it that patients in oncology on admission are now, and this is very new, it's just starting and we have to implement it more widely. But the idea is that patients, when they are admitted to oncology, in an inpatient setting at the moment, they get the distress thermometer from psycho-oncology and they get the full IPOS from palliative care. If they come to the outpatient setting, they have the option of the digital screening. That is where we use the shorter version of the IPOS 5, and the distress thermometer is also reduced because it was felt that patients are too burdened if every specialty comes with a long list of items. And when we have sort of our cutoffs, then there is a referral to palliative care automatically provided to the oncologists so that he or she is highlighted to the needs of the patient. And then they can send off a request for specialist palliative care consultation, and our consult team would then come on the ward. This is obviously the ideal world. As I say, we are just starting, and we are working here in a huge university hospital with almost 2,000 beds. So introducing the screening in all the departments looking after oncology patients is actually quite challenging. So we started with neurosurgery and with radiotherapy and the lung cancer center. But obviously the idea is to roll it out more widely. And again, when patients are having the cutoffs, and we're doing sort of more statistical tests to identify the right cutoffs, but at the moment clinically, and the first tests say that we are actually quite good with the 2 times overwhelming or 3 times severe, that would be a help to identify patients who could benefit from specialist palliative care. I hope that makes it clearer.
Yes, I think it's very clear, and you're working on the cutoff further to make it more accurate to refer patients to palliative care. Yeah, thank you. And there's a question which is asking, in PCOM or IPOS, what is the dropout rates in the study?
The dropout rate in the study, let me think, which study are you asking about? Are you asking about the EAPC use? Actually, the dropout rate was because of deterioration over time. I haven't got it in mind, actually. I just have a look. I closed the presentation already. So let me just see. Here we are. So we had 82 patients participating in the study period, completing the EAPOS, and in the end, 60 completed the whole study period. So there was a dropout of almost 25%, 22 out of 82. But again, as I say, it's very much linked to the special situation that we have in Germany for specialist palliative home care, because it is because of organizational and financial issues related very much to the end of life. So our conclusion was almost that these patients are almost too ill to use the electronic version. We want to develop an app now, which might make it easier rather than to use their own device. They have to go to the computer to use the tablet. So the next step we want to do is to develop an app for IPOS where we can actually include different languages and different versions. We are also thinking about doing a relative version. There are versions, or a family version, there's the proxy version for professionals, but in home care it might be helpful to have the support of the family actually to assess the situation of the patient. So that is another step we are planning in the future.
Okay, thank you for that. And there's a question which is asking about the necessity to validate or adapt the instrument for different illnesses such as COPD, heart failure.
There are publications, and I think it's even validation work for heart failure. I've seen that. We used IPOS. No, sorry, that was POS. That was POS. We used it in COPD patients. So I think the question is, do you need to validate the whole instrument, or do you need to actually add some of the specific symptoms, which has been done, for example, for neurology or renal patients? So you could add some specific symptoms, either based on the prevalence or do some validation work, for example, for COPD. That's obviously the challenge. But I think the beauty of IPOS is that you always have one version, the original version, that has been validated in different patient groups. So it was a mixed population when we originally validated it. It was not only oncology, but also patients with non-cancer diagnosis. And we validated it across settings. So not only in the inpatient setting, but also in the community setting. So I think the original IPOS version is always good to use. And you can look at some of the work for the Neuropal or Fix, for example, the COVID version now, where you have specific COVID version symptoms that are added. And again, the group at King's has done some validation work there.
Okay, thank you for that. And there's another comprehensive question about the, I think, scoring. So I think when using healthcare proxy for this course, what are the main challenges that you face, and how do you ensure accuracy? And they also have asked, how do you improve this, as I find it difficult to ask each item using the Likert scale in a clinical setting?
Okay. So there's always this challenge about patient and proxy ratings, and the inter-rater reliability for IPOS in the study has been sort of fairly good, but obviously not optimal. And you can say, okay, that's a weakness. In the clinical setting, I think it's actually an opportunity. If you ask a patient to assess the situation and you do it yourself, and we've done that on the ward, you might actually see some differences. So you can say, okay, the staff is not trained well enough and there is some training necessary, but you can also consider the situation and then discuss it with the patient and say, oh, this is interesting. You have rated your breathlessness less burdensome than I actually have rated it. So let's discuss it. Let's understand it better. Or say, okay, I didn't notice that you have dry mouths, that you have a sore mouth. Obviously, that's much more difficult to assess. But you say you're very burdened about it. So it could be an opportunity to get into a conversation of the patient. Obviously, if you use it as a research tool, you have to be very clear, because you shouldn't mix the data to have a patient rated version and the proxy rated version. So you need to decide either or. But if you use it for proxies, obviously some training would be really good and helpful. And I didn't mention yet, there are every year at King's, we're running, or the King's team mainly is running with Murta, up so-called POS days, where actually patients can go, where interested people, professionals can go for training, for example. And there are quite a number of resources from Resolve, which I've added on the last slide, from Hull, where Murta, they provided little videos, little leaflets with 2 to 3 pages, where they described what is necessary, where you have to pay attention when you're using IPOS.
So I understand the answer is there is a difference between proxy and as done by the patient, yeah. But it could be used as a tool to start a conversation with the patient.
Absolutely. And hopefully in many items you actually agree, or you have the same rating. But if there is difference, I would see it as an opportunity rather than as a fault or a wrong rating.
Thank you. So another question which is asking, advantages of IPOS and other prompts are well known, but healthcare professionals sometimes find them time consuming. So how can we motivate healthcare professionals to use this instrument more in the clinical practice?
I have a consultant who went to another palliative care unit yesterday or last week because they wanted to be certified. And they're not using IPOS or any outcome measures, neither palliative phase nor AKPS. And he came back and said, I was really missing something, because in a way, I'm missing the framework where I understand the patient situation better and actually have it operationalized. So there is a high burden or not high burden. It could be a burden if you feel, oh, we have to do that as an add-on. We have to assess patients extra. But we had teams who said, wow, using these outcome measures actually reduces our free text documentation of the patient in everyday clinical care. The nurses are writing free texts, the doctors are writing free texts. If you have an outcome measure like IPOS, you don't need to describe how the pain is, how it's changing over time, how the other symptoms are, because you can see it immediately. And I think the challenge is not to say you have to do that on top, and even say, then people interpret it as research and say, oh, we are only collecting research data. That's why we're not talking about research at all, because that's not research. And we're also not talking about data collection. We actually talk about daily assessments, and that's why we call it vital signs. It's without doubt that on a normal general unit in the hospital, you take blood pressure, you take heart rate, you measure the temperature, and everybody knows how to do it, and everybody knows the references. There's no question about that. Well, why don't we do a similar thing in palliative care? That's why we call it vital signs, but I think it's very obvious that for patients, it's not relevant how their heart rate is or their temperature. It's relevant how their pain is, how their breathlessness is, how their worries are, how their problems and practical problems are. And that's, in a way, how we try to introduce it. Obviously, then it's a challenge to use it consistently, to develop this common language. And it's nothing that's going sort of from here to now. You say, I, as a head of department, say, I want that you do it, and then it's work. Actually, it is quite a laborious process. And we are still, despite including it in everyday clinical work, we still have people who really struggle with it and think, oh, we are reducing patients here to some numbers. But that's not the idea. So that would be sort of part of it. Obviously, if you have opportunities for training, if you can identify champions who really are are enthused about it, engaged about it, that is extremely helpful.
Absolutely right. I agree with you, Professor Claudia. If we don't do the symptoms, then we are not knowing whether we are treating the symptoms effectively.
Absolutely.
So that shouldn't be considered as time consuming at all. Yeah. Thank you for that brilliant explanation. I think we have come to the end of the session. I don't see any more questions in the question box. Okay, there's one. Okay, this gone in the chat box, I think.
Yeah, I'm just reading it.
Yeah.
There's a question about when patients and relatives are unaware and illiterate that the idea of outcome measure is far-fetched. I think I wouldn't talk to them about outcome measure. I would really talk to them their very simple language so I understand. You're suffering from pain. We want to improve your pain. Obviously, that's why we have to assess your pain now. And we give you some opioids, drugs, whatever, to make the pain better, and then we will reassess it regularly. So I wouldn't talk to patients, even to professionals. If you talk it to outcome measurement, that sounds very much like research and number collecting. I really would talk very simple language and explain what is behind the idea that we do regular assessments and that we see, hopefully, that pain, other symptoms are being reduced or other burden. And I think that's the core of palliative care, what we want to do.
I think there's a question, but which is not very relevant to IPOS. I mean, I think what they're trying to ask is, have you integrated qualitative data, text, audio, or video into the outcome measures?
I think, well, if we do research about outcome measurement, I showed you a very short snapshot on the feasibility of the electronic IPOS version. We tend to really do mixed method studies and do qualitative work, understand what the professional thinks, understand what patients and relatives think. So I think if we develop something new, if you evaluate something, we should definitely do mixed methods work. And the problem is in everyday clinical work, it is also a form of mixed methods because we assess the symptom and the situation, but that doesn't mean you're not talking to them. The talking, I would in a way say that's the qualitative part, but obviously the tool helps you to structure your conversation, to focus on blind spots, because I think we all have blind spots when we assess the situation of patients. But the tool helps you, and then you can actually use that for the conversation with patients. So that would be the qualitative part for me if I translate it in my mind. But that's obviously not qualitative work like research. That's what we do in research.
Okay. Have you done any work at rehabilitation outcome measures for palliative care?
Sorry, that have I got?
any work looking at rehabilitation outcome measures?
No, I'm not very experienced at that, but I have to refer again to King's. There are a few physiotherapists working in the Department of Palliative Care, or the Cecily Saunders Institute, and they have done a lot of work on rehabilitation, actually coming from the rehabilitation angle, but now actually bringing palliative care and rehabilitation together. So I would look on the King's website, Cecily Saunders Institute, and see what they've done on that. But I haven't got any experience. Neither have I got experience with experience measures. And I think one of the questions was also about satisfaction measures. Satisfaction, I think, is quite challenging because I think satisfaction is something very subjective. If I'm very provocative, I would say you can be very kind to a patient, have a nice conversation, and the patient feels really well, but you can do the worst pain management. So satisfaction, I think, is something very subjective and is probably very influenced by many factors. And the question is there really a good satisfaction measures? I think there is, well, I'm not experienced in that. And I just digged out that from IPOS, there is one measure which is called Views on Care. You can also download it from the POSPAD website. And that's actually asking about the rating of the overall quality of life before you started seeing the palliative care team, and taking everything into account. Do you think the team is making a difference? So that would be some sort of views on care. You can also say satisfaction, but I think satisfaction for me is a challenging construct, and I'm not sort of entirely sure whether I'm convinced of it.
Thank you very much, Professor Claudia Bausewein, for the excellent talk today, and thank all the participants for attending this webinar. And if there are any queries, please contact the EAPC JF team, and we'll continue to hold webinars and look forward to see you in another webinar. And thank you very much all. And we come to the end of the webinar. Thank you. Thank you very much.
Thank you, everybody.
Thank you for inviting me. Thanks a lot.
Thank you very much, Claudia. Wonderful.